title of today's presentation is The Approach of the Patient with Abnormal Liver Tests, Part 2. I have no financial relationships related to the subject matter of this program. In Part 1 of this presentation, we discussed the common liver chemistry abnormalities and specific disorders in which a serologic evaluation was indicated. In this presentation, the learning objectives are to describe specific features of chronic hepatitis for which the serologic evaluation is performed, and describe specific features of chronic cholestatic disorders for which serologic evaluation is performed. As a review, the approach to the patient with elevated serum transaminases is illustrated in this slide. The serologic evaluation includes anti-nuclear and anti-smooth muscle antibodies, total iron binding capacity and serum ferritin, hepatitis C virus antibody, and if positive, hepatitis C viral RNA by PCR. Hepatitis B surface antigen with a consideration for a determination of hepatitis B viral DNA levels, serum protein electrophoresis, and consideration of a alpha-1 antitrypsin level, serum ceruloplasmin, and a confirmatory urine for 24-hour copper. And finally, endomyocele and tissue transglutaminase antibodies. Autoimmune hepatitis would be evaluated with the anti-nuclear and anti-smooth muscle antibodies. It's particularly important to distinguish autoimmune hepatitis from other forms of liver disease given the response to immunosuppressive therapy. As a review, type 1 autoimmune hepatitis, the most common type seen in the United States, is defined by a positive ANA and or smooth muscle antibody. 25% of patients with type 1 autoimmune hepatitis will be ANA negative but smooth muscle antibody positive. There's a rare form of type 2 autoimmune hepatitis that affects largely adolescents in which a liver-kidney microsomal antibody is positive. Autoimmune hepatitis is also characteristically defined by hypergammaglobulinemia with an IgG fraction predominant. There's a 3-to-1 female-to-male ratio, and a strong association with other autoimmune disorders, in which approximately 40% of patients will exhibit other forms of autoimmune behavior. A liver biopsy may be required in autoimmune hepatitis to make the diagnosis. And it's also important to recognize that there are acute and fulminant presentations of autoimmune hepatitis, although the classic presentation is a chronic hepatitis. The associated disorders of autoimmune hepatitis include thyroid disease, particularly hyperthyroidism, rheumatoid arthritis, diabetes mellitus, and celiac disease. Hemochromatosis is an autosomal recessive disorder of iron absorption. It's a very common gene mutation. Approximately 10% of Caucasians of Northern European descent will carry one of the mutated genes. However, it is a disorder that is associated with low penetrance, so that there is a broad phenotype exhibited. The classic presentation of cirrhosis and bronze diabetes nowadays is extremely uncommon. The most common presenting symptom of hemochromatosis to the primary care provider is arthralgia, and the patient may also complain of loss of libido. Two important mutations in the HFE gene that's abnormal in hemochromatosis are the C282Y and the H63D mutation. Patients that are homozygote for the C282Y allele will have hemochromatosis, and patients that exhibit a compound heterozygosity for C282Y and H63D will have hemochromatosis. Interestingly enough, patients who are homozygote for H63D do not have the disease. Liver biopsy nowadays is largely performed for prognostic rather than diagnostic indications. Phlebotomy in the non-cirrhotic patient is associated with normal survival, pointing out the importance of making the diagnosis of hemochromatosis at an early stage. Associated disorders that may suggest the diagnosis of chronic hepatitis C include mixed cryoglobulinemia, a membranous proliferative glomerulonephritis, the skin disorder porphyria cutanea tarda. It's a higher incidence of diabetes mellitus in patients with chronic hepatitis C, and patients with B-cell non-Hodgkin lymphoma have been shown to have a higher incidence of chronic hepatitis C. Disorders associated with chronic hepatitis B include polyarteritis nodosa and membranous nephropathy. Turning to other forms of viral hepatitis, I would just make note that cholestatic injury patterns may help distinguish Epstein-Barr virus hepatitis from other forms of viral hepatitis. In addition, a marked AST, more so than an ALT elevation, compared to a mild hyperbilirubinemia, may be seen in fulminant herpes simplex virus hepatitis. Alpha-1 antitrypsin deficiency, as mentioned in the previous talk, is an autosomal recessive disorder Alpha-1 antitrypsin is a serine protease inhibitor that inhibits neutrophil elastase. The liver disease is secondary to defective export of the mutated protein, and lung disease is secondary to the deficiency of the protein in the blood. Patients usually present with either liver disease or lung disease rather than both. An absent alpha-1 globulin peak on the serum protein electrophoresis suggests the diagnosis. Protease inhibitor phenotyping confirms the diagnosis. And liver biopsy may show the characteristic PAS-positive granules. As discussed in the previous presentation, Wilson's disease is another autosomal recessive liver disorder, this of copper metabolism. It's characterized by abnormal hepatic accumulation of copper and low ceruloplasmin activity. The gene responsible, ATP7B, has been identified. Of note, late-onset Wilson's disease is frequently overlooked. Late onset meaning a disease presenting beyond the age of 40. Wilson's disease must be excluded in any patient with unexplained liver disease along with neurologic or neuropsychiatric disorder. Illustrated in this slide are the characteristic Kaiser-Fleischer rings, the brown discoloration in Descemet's membrane in the cornea of a patient with Wilson's disease, and copper deposition in the central nervous system. As discussed in the previous talk, celiac disease needs to be ruled out in patients with abnormal liver chemistries. The prevalence of abnormal liver chemistries is approximately 5%. And it should be recognized that celiac disease is a common condition that can be diagnosed at any age and affects many organ systems. In the adult, subclinical disease manifestations are the norm, iron deficiency anemia and metabolic bone disease being the most common manifestations. Turning to causes of elevated serum alkaline phosphatase, as discussed in the previous presentation, the serologic evaluation is largely limited to determination of an anti-mitochondrial antibody, and imaging takes precedence in the approach to the patient with elevated serum alkaline phosphatase. Primary biliary cirrhosis is a chronic and progressive cholestatic disorder of unknown etiology that's characterized by inflammation and progressive destruction of the interlobular bile ducts. It has a female-to-male ratio of 9:1, and the anti-mitochondrial antibody is positive in approximately 95% of patients with primary biliary cirrhosis. Patients also may exhibit hypergammaglobulinemia with the IgM fraction predominant. And over 50% of patients with primary biliary cirrhosis will have associated autoimmune disorders, including thyroid dysfunction, usually presenting with hypothyroidism, Zika syndrome, presenting with dry eyes and dry mouth, and celiac disease. Finally, primary sclerosing cholangitis is a chronic cholestatic disorder characterized by progressive inflammation, destruction, and fibrosis of intrahepatic and extrahepatic bile ducts that may present with elevated alkaline phosphatase. It affects predominantly men in their 4th and 5th decade. It's commonly associated with inflammatory bowel disease, particularly ulcerative colitis. Approximately 70% of patients with primary sclerosing cholangitis will have underlying ulcerative colitis. In contrast, approximately 7% of patients with ulcerative colitis may develop primary sclerosing cholangitis. Unfortunately, there's no serologic marker for primary sclerosing cholangitis, and the diagnosis requires magnetic resonance cholangiopancreatography or endoscopic retrograde cholangiopancreatography. The subsequent talks in this series will provide more detailed information about the epidemiology, clinical manifestations, and in particular the treatment of the disorders discussed in this talk.